we can go ahead and get started early, but I want to welcome everyone. And also, before I forget, I'll make an announcement about the next event, which is in May, but I'll just let you know what it's about. But First of all, I'd like to introduce Sandy Leathers and Danita Nash from the North Carolina Department of Health and Human Services, the Office of Minority Health. Did I get that right?
That's
All
right.
right, good morning.
And
So,
we also have another colleague. I'm sorry, Dr. Fulmer.
oh, no, that's all right.
We also have Juan Ortiz here
Oh, yes, I
from
see.
the Office of Minority Health and Health.
Hi, Juan. Yes, I saw you on the email, so it's nice to meet you.
Good morning. Likewise.
All right, good morning. And this group, the Office of Minority Health, is the first of our speaker series from the North Carolina Coalition on Aging's Health Equity Committee. And Rosalie Calarco is here. She is our co-chair of the Health Equity Committee. So, Rosalie, did you want to say good morning and hello to everyone?
Yes, good morning, everyone. Thank you for joining us today. And we're very thrilled to have uh, Sandy, Danita, and Juan with us from the North Carolina Department of Health and Human Services Office of, why did I just blank on y'all's office? Oh my God.
Minority
Office
Health, Minority
Minority
Health.
Health.
of
Thank
Health
you.
Health Disparities. Yes.
Um, and I think a few folks might have been on when Sandy and Danita were on our meeting previous.
Mhm.
So we really appreciated you all taking the time to present to us today. So thank you.
This is wonderful. And I see that Dalton Bailey has arrived. So Dalton and Rosalie have co-chaired the previous work group on rural initiatives. And Mary Williams Stover and I think Lindsay Golden is coming. Both have co-chaired the work group on the BIPOC initiatives and dementia concerns. And Heather Carter and Katie Kutcher have co-chaired, good morning, Heather, the work group on LGBTQ plus initiatives. So I think we have representatives from everyone, and we are very happy to have Sandy, Danita, and Juan on this morning to give us an overview of what has been happening in our new landscape so that we're all aware of what's happening, where we need to
Okay.
go, and what we need to think about, and all those things. So I'm going to say, let's get started so that we won't miss your timing. So thank you. Before, let me
Go
just
on.
say, Mary Bethel is the president of the coalition, and Sandra Phelps is our what should I say, executive director
That's
of the
right.
coalition. And so thank you all for being here this morning. We really, truly appreciate you. So Sandy and Danita and Juan, take it away.
Absolutely. If you will just give me a moment to share my screen, I'll go on and get the presentation up for everyone.
Yep,
Can
I
you?
just gave you the ability to do that, I think.
Okay. All right.
Oh, yes, excuse me. I see that Mary, you put a note in to welcome Ashley. Is it Ashley Freddie? Did I say that correctly? Mary,
Um, I always
is
say
that
Freed.
correct?
I'm not sure.
Sorry,
Free,
it's pretty. Sorry, I'm
Yeah.
on
Freedy.
the phone
Okay,
real
Freedy.
quick. So sorry.
That's okay, Ashley. We appreciate you being here. From the North Carolina Health News?
Mhm.
Okay, great. Wonderful.
All right. Before we begin, I'm just going to give my colleagues an opportunity to introduce themselves. Also, you'll give my screen a chance to get ready for this thing. So again, we are happy to be here. I am Sandy Leathers with the Department of Health and Human Services Office of Minority Health and Health Disparities. My expertise on the team is from communications, health education, and messaging. And just a tiny little background on me, lots of years in public health from Virginia, actually. And I've been with the office since 2023, right after COVID, background in epidemiology and public health. And you've got all the senior members of the team here today. So I'm really happy to have my colleagues. I'll give them a chance to quickly introduce themselves. I'll pass to Juan.
Good morning, everyone, and thanks again for inviting us and having us here today. My name is Juan Ortiz, and I'm the Program Manager for Cultural Competency and Language Access at the Office of Minority Health and Health Disparities. This is a great opportunity, and we are very thankful and honored that you decided to partner with us, and we look forward to many different activities where we could share some of the lessons learned from working in this field. And I will stop blabbing and hand the mic to Danita.
All right. Thank you, Juan. And good morning, everyone. I am Danita Nash. I work with the Minority Diabetes Prevention Program, the North Carolina Minority Diabetes Prevention Program, and Community and Partner Engagement. I've been with the office for the past year, but been with NCDHHS since January of 2021. Started working on the COVID-19 Impact Project, moved over to DPH, and now I'm back in this office. So in the words of Juan, thank you so much. We are excited about this collaboration, and Juan and Sandy and I are happy to be here. And Juan said, thank you for this collaboration, this new partnership. We appreciate you. Thank you for having us.
Thank you so much. And again, I'm just going to this gave me an opportunity to give a formal welcome to you all. We'll get right into the report. We will have opportunity, lots of time following the presentation to answer questions. So feel free at the end of this presentation to, excuse me, drop your questions in the chat or raise your hand, and I will be certain to answer questions in the discussion section. So with that, I'm going to get started. All right. So, as you know, the North Carolina Department of Health and Human Services, Office of Minority Health and Health Disparities, we produce what is called the Health Disparities Analysis Report. This report that we put out is unique to the state. It is our state's key signature report for understanding health inequalities. And we put it out about every 3 to 5 years. So this is the latest report that was produced in fall of 2024, 2025, sorry. And the purpose of this report was to highlight the most significant health disparities in North Carolina as opportunities to reduce disparities over the next 3 years. Also to measure and provide a starting point to track the state's progress on eliminating health gaps experienced by populations that have been historically marginalized. It describes the services, programs, and resources dedicated to addressing disparities, emphasizing actionable strategies to reduce health disparities and seek solutions. So that is the general gist of the report. The report, which we'll provide at the end of this presentation for your review and feedback, is written in a report grading style. So disparities that are equal with the source population will receive an A or better. And as the disparities increase or decrease, depending on what we're measuring, you'll see the corresponding grade. Okay, so the report is identified by 6 key categories in health disparities. Social drivers of health, that's pretty common. We're talking about where you live, how you learn, what you do for work, your age, and how all those factors shape your health. Some communities in North Carolina have lots of resources to help people stay healthy, and others don't have that support. So we measure that. We also measure access to care, asking questions like if you can afford your medications. Are there enough primary and specialized providers in your community? Excuse me. Do you feel safe, respected, valued by your healthcare provider or in a healthcare setting? So when we're talking about access to care, we're not talking just about your proximity to care, but the kind of care that you need and you're getting. There's also chronic disease, of course, which is your long-term diseases, your basic heart disease, cancer, injuries, diabetes, things that often develop due to mix of health behaviors, some genetics and environment. So these diseases are major causes of death in North Carolina, and we're looking to see how those diseases play out in different communities. And of course, communicable disease, mental health, substance abuse, suicide prevention, and health across the lifespan. So looking at that cradle to grave health happening in our state, what's unique about it. Today, we're going to focus on I'm going to speak on the key takeaways of the disparities from the report. And then later we'll discuss how senior populations came out in this presentation. Okay. And I'm double duty with I got two computers up here. All right. So social drivers of health, looking at that first disparities topic we were discussing. These are the key takeaways that we found. Key takeaways from the report found that African Americans, American Indians, and Hispanic populations were more likely to have low median household incomes, higher unemployment, higher poverty rates, and greater housing cost burden. In fact, these groups are more likely to spend over 30% of their income on housing. So it's not difficult to surmise how these drivers influence health outcomes for these communities. For seniors, we saw outcomes that were influenced by income, of course, but also transportation, housing, access to healthy food and healthy care. For most seniors, that looks like fixed incomes, transportation challenges, social isolation. Those factors impacted people's abilities to stay healthy. All right. I'm getting an urge to say next slide, but I don't have to say that because I'm driving. All right. So looking at access to care, some additional takeaways from the access to care section of the report. Our findings determined that Hispanic or Latinx individuals were 4 times more likely to not have health insurance compared to their white counterparts that are non-Hispanic. American Indians, in fact, are twice as likely, and African Americans are 1.5 times more likely, as well as multiracial people, being 1.3 times more likely to not have health insurance. And I want to put a slight disclaimer in here. We have to factor in that this report was run before Medicaid expansion, and then also after Medicaid expansion was limited due to Title I. Well, I won't say the name of it, but changes to the Medicaid program. Hispanic, African Americans, and multiracial people are more likely to not see a doctor due to cost or cost being too high. Okay. For people with disabilities, and I pulled this particular disparity point because it's just so overwhelming. People with disabilities, regardless of their race identified, were 2.5 to 4 times more likely to avoid seeing a doctor altogether as compared to their white counterparts who do not have disabilities. Moreover, Latinx individuals with a disability were nearly 7 times, 6.82 times to be exact, more likely to not have insurance compared to their white counterparts, and also not receive care or visit a doctor because of their insurance status. Okay, next slide. We also looked at rural communities, which is we're reframing what we identify. Rural populations do have history of marginalization, so we look at rural communities as well. And of course, this being North Carolina, it is a very rural state, so it's impacted by what happens to people in rural settings. About 74 counties in North Carolina have currently a shortage of primary care providers, with a ratio of greater than 1,500 residents per one healthcare provider, one primary healthcare provider. That means that nearly 75% of counties in North Carolina lack enough primary care access. And as you may surmise or recognize with the changes from the federal government, that gap may be increasing as we speak. Right, we're switching to chronic disease. The third category from our report, these were the key takeaways that I found that would be interesting to share. North Carolina has made great strides to reduce disparity gaps between racial and ethnic population groups. However, Black North Carolinians are more likely to still die from stroke, more likely to be diagnosed with and die as a result of diabetes, complications of diabetes, and more likely to be diagnosed with COPD or chronic obstructive pulmonary disease, and more likely to have kidney disease causing mortality as compared to their white non-Hispanic counterparts. Black Americans in North Carolina are also twice as likely to develop prostate cancer and 2.5 times as likely to be diagnosed with multiple myeloma, more than likely to die of cancers in general, according to our findings. This is also true for American Indians, who were more likely to have mortality related to diabetes diagnosis, liver disease, kidney disease, Alzheimer's, as related or as compared to their white non-Hispanic counterparts. And for older individuals, as you know, they're more likely to experience heart disease, diabetes, and the like. But many of these conditions, some of these conditions can be prevented and managed with early screening and lifestyle change. So, moving on. Moving on to mental health disparity key takeaways. These were just a general summary. Again, most of these disparities, these topics of the report have more in-depth findings, but I'm just giving you the top line. Just in the interest of time, the report is over 200 pages. Well, it's not. It's over. I want to say it's over 50 slides, 50 pages now. It used to be a lot larger, sorry. But the summary are top of line that are here for you just to make the presentation a little easier to digest, because it is a lot of information. But nationally, again, women, young adults, and people of color, especially American Indians and multiracial people, are more likely to report a serious mental health diagnosis. In North Carolina, however, we're seeing that increasing in high school students, adolescent students who are who have marked increasing reporting of loneliness, sadness, hopelessness, suicidal behavior, and feeling unsafe in school or physical dating violence. Next slide. Okay, key takeaways from substance abuse. I thought these disparities were of note. I really wanted to share these. I find it very interesting for people who are incarcerated or recently released from incarceration. Those people we found were 40 times more likely to die of an overdose in the first 2 weeks upon release than compared to general populations. I found that disparity quite striking. Over the past decade, rates among I'm sorry, I skipped ahead of myself. People experiencing housing insecurity, North Carolinians that do not have a home are 13.8 times more likely to die from overdose than housed population, people that live in homes. Over the past decade, overdose rates have increased among groups that are historically marginalized, including American Indians, African Americans, Hispanic, and Asian populations. However, over the past decade, overdose rates, let me slow down, overdose rates among white North Carolinians rose substantially, but not as sharp as some minority groups. In fact, in the most recent year, 2022 to 2023, white populations were the only group to see a decline in overdose deaths related to substance abuse, while other groups held steady or continued to climb. And of course, people living in rural communities are more likely to have an alcohol root cause related death as opposed to those living in urban areas. That was across the board. Wrong button. Sorry about that. Okay. Looking at finally health across the lifespan, here are our key takeaways. We continue to see, as it compares to on a national standard, that Black women in North Carolina are 1.5 times more likely to die from causes related to pregnancy as compared to white women. Infant mortality is highest for African Americans infants, followed by American Indian and multiracial infants. So child and infant mortality is still twice as likely for Black and American Indian children as compared to white children in North Carolina. And as of 2021, North Carolina was ranked 10th in highest infant mortality rate. Okay. More health across the lifespan takeaways. In North Carolina, families spend an average of $9,000 to $9,850 per year for full-time childcare. And that number is absolutely on the rise. Over 22,600 students K through 12 are homeless in North Carolina. This was of our last reporting in 2022. 99% of youth in North Carolina in a developmental center have a mental health diagnosis, and 48 have both a mental health and substance abuse or substance use diagnosis. Oopsie, sorry. Okay. Violence prevention is also included in mental health, suicide, and violence prevention. They're all in one category. High levels of exposure to violence. We want to remind, it's in that group of mental health because high levels of exposure to violence can reinforce cycles of trauma and can worsen mental health. In fact, more than half of U.S. adults worry about a loved one being the victim of violence. But I thought a key takeaway to share with our partners today: people with mental health diagnoses are 3 times more likely to be the victim, not the perpetrator of violence. North Carolinian American Indians, African Americans are more likely to be involved in a violent assault, firearm death, injury, or homicide. And firearms are the leading method involved in suicide and homicides in North Carolina, representing 57.3% and 75.8% respectively. Okay, now we're going to talk about the disparities we found just in North Carolina aging adults. In over half of North Carolina counties, at least 1 in 5 people is 65 or older. And by 2031, there will be more older adults, meaning 65 or older, than children in our state. Older adults are also more vulnerable to health issues because they may be less socially active or interactive and be less involved with work or experience a financial difficulty due to fixed or lower incomes. And again, as I said earlier, a lot of especially chronic diseases, we have accepted as a community, you're older, that'll just happen. But a lot of these conditions are preventable and can be managed with early screening, intervention, and lifestyle changes. So we don't have to accept that chronic disease will just happen to seniors. We don't have to accept that. Thank you. Okay, moving my slides on both sides. All right. We also saw that about 10% of older North Carolinians have an income below the poverty level, and 20% have income between 100 and 199% of the poverty level. So they represent a disproportionate percentage of people living below the poverty line. Most seniors, about 83%, have 1 or more chronic diseases. 34% self-identified as disabled, either mental or physically disabled, and 70% self-reported having poor health. Falls was a big one in our report for senior populations. You were 65 adults 65 and older were 5.5 times more likely to die related to a fall-related injury. 4.5 times, more likely to be hospitalized due to a fall, and 2.6 times more likely to visit the emergency department due to falls. So falls are preventable. I just want to remind the audience of that. And community programs help increasingly to reduce risk. Good examples of those are home safety improvements, strength and balancing programs, and programs that improve vision or medication checks. Those are some of the common sources or root causes of falls Well, healthy aging requires preventative care, community support, and accessible to healthy information. And that's a great segue into our next subject, why health literacy matters. And I will pass.
Thank you so much, Amy. This is Juan Ortiz again.
Can we ask questions before you start? Is that possible? Are you okay with that, Daryl?
We were going to go
I'm so
ahead.
sorry. I'm okay with that, but I know that some of them have to leave.
Yeah.
Okay. All right,
So-
that's good. I'll hold it then.
You can? Okay.
Mhm.
All right,
ahead.
Juan, you could go
Yeah.
ahead.
Yeah.
We appreciate it. And yes, we'll definitely do questions and answers right after the presentation. So we appreciate your patience. So thanks again. This is Juan Ortiz, and Sandy just provided a high level sort of the mechanics of why this health disparity report that our office puts together can be helpful for people to give the context as to how do health disparities affect North Carolinians, especially old North Carolina, and how they experience it. And so now we're going to talk about how health literacy may also be one of those tools that can help us improve health outcomes for older North Carolinians. So in which ways can we say the health literacy efforts can improve the health outcomes for older adult communities in North Carolina? In one sense, it can help find the needed health information for older adult communities in North Carolina. It also can improve the process of understanding health instructions, which in some situations can be the difference between people experiencing improvement in health versus people not knowing what to do with the information they've been given or that providers have shared with them. And then the other way that health literacy can be helpful is it can help the patients as well as the providers to make informed decisions about their health. And so that's why we think health literacy efforts are a very useful tool to get folks to have more control and more ownership of their own health. Sandy, if you can if you could advance the slide for me, thank you so much. So as Sandy alluded to, an example of an effective health literacy campaign intended for older adults it's intended for older adults to help them by educating them into preventing falls and injuries among that population. It also helps to understand treatment plans for falls, especially for musculoskeletal injuries. It also health literacy campaigns can also help access preventive care, and in some cases, especially at the advent of the the Affordable Care Act, a lot of preventive care services have been more accessible. So that is a way that you can tie together health literacy for older adults in the existing benefits of Affordable Care Act. And also it can help communities navigate the changes in the safety net, such as Medicare and nutrition support services. So those are ways that effective health literacy campaigns can help in older adult communities. Another important consideration in health literacy for older adults is especially in what is called minoritized communities, is that health literacy can help providers identify preferred language. It could help providers of services identify how to be able to provide American Sign Language communication, nonverbal. It can help with creating material that is more likely to have pictorials versus text, especially when people are not only don't have access to or don't have English as a first language, but also when they have visual issues. And so pictorials can be a saving grace. Also appealing to cultural values and beliefs. Some communities, some older adult communities are very connected with their faith-based organizations. And so partnering with faith health organizations to do health literacy is a key an effective strategy when you're talking about health literacy in older adults. Next slide, please. Same. So now we're going to talk about the relationship between health literacy and engaging communities and partners. So at the Office of Minority Health and Health Disparities, we have put together what we're calling a community and partner engagement framework. And what we've done is we created a visual aid graphic that helps people have a quick reference, especially helps those folks that are working with older adult communities. This particular graphic can be a quick reference to figure out how to go in the most meaningful way, how to engage communities, especially if you're a provider that's engaging the aging adult communities for the first time. These are some, this can give you an idea of where to start and how to go sort of step by step in the process of engagement. So this particular framework incorporates elements of communication, equity, and access. It also addresses partnership with community and community-based organizations. It incorporates elements of cultural competency and language appropriate service provision, as well as it promotes the shared decision making. And I'll speak a little bit about what that means, shared decision making between the patient or the consumer and the provider. Communities should be partners in shaping health information and outreach efforts. Building these partnerships are essential to eliminating disparities. Go ahead and go to the next slide, Sandy, please. We've also have created aside from the framework of community and partner engagement, we've also created a guide. And right now we're working on updating the guide to be more reflective of our most recent what we're encountering in terms of issues by virtue of having a new administration in power that has changed some of the landscape. And so we want to make sure that this community and partner engagement reflects those changes, and also it equips communities to be able to seek solutions to the new challenges. So we're in the process of doing some quick updates, but this should be available to anybody who's interested within the next couple of months, and we'll definitely let you know. But this is something that we still use as we share collaborations with different partners, both internally and externally. So be on the lookout for that. We'll definitely let you know what the status of this update for this guide is. And so we'll be more than happy to share it with you. Sandy, if you could please advance to slide 22. And we can talk about that. Sorry that I'm changing the script on you. So I wanted to talk about something I said earlier about why we believe that senior health literacy and advocacy should be a shared responsibility. First, I'm going to say something that I meant to say to you earlier, but we recognize and we acknowledge that all of you present here are subject matter experts, and we want to honor that. We want to make sure that the information we bring to the table today can go into your toolkit that you use on a regular basis. So we want to acknowledge your expertise. That said, we also want to make sure that we remind everybody that we work with that in the case of adult, the aging adult population, just like any other community in North Carolina, they have challenges, but they also have strengths. And those strengths are always brought to the table, and we feel like it's important. We feel that it's important that we recognize that older adult communities have natural strengths. For instance, they have lived experience, capacity for self-advocacy, cultural protective factors, and also they utilize clear and respectful communication as a rule. So we want to make sure that when we engage with older adult communities and we talk about health literacy, we bring these elements into the table so we connect those points. Also, when it comes to partnerships, we want to make sure that there are partnerships established between patients, consumers, and their providers. So that's the reason why we feel very strongly that health literacy, understanding health literacy, internalizing health literacy, and being able to apply health literacy has to be a shared responsibility. And how do we feel that that responsibility can be materialized is when it comes to navigating the health system. We all know that our current health system has become so convoluted, and even people who are considered to be experts have a hard time navigating that system. So can you imagine, and I'm sure you could, how older adults, consumers can sometimes be so overwhelmed by the constant change in the landscape. And so that's where partnerships come to play an important role. So we want to make sure that remains the case. Many individuals in the older adult communities experience chronic illness. In managing chronic illness such as diabetes, heart disease, hypertension, sometimes that's where the disparities in health and the outcomes tend to be substandard. So we want to make sure that chronic illness is being given the priority that it needs to be given. And also, as we have found in some communities, especially rural communities and communities that have interrupted access to services, these disparities compound over time. So we need to be alert and be on the lookout for that as well. And Sandy also alluded to the idea of structural barriers that exist, especially with safety net programs such as Medicaid and also medication access. You know, until recently, we were lucky to have folks that are dependent on insulin, for instance, we're given a break by having access to insulin at generic prices, and now there's sort of a sense of right now there's a sense of insecurity and uncertainty as to what's going to happen to that. So we want to make sure that folks partner up with different communities and stakeholders that can help them figure out what the status of such things are. And then I want to talk about co-creating a space for empowerment. So I'm a social worker by trade, and we were trained, or I was trained to not use empowerment in the sense that we empower people, but people empower themselves. So we want to make sure that we keep keep up with that mindset. So to improve provider-driven health literacy support is at the forefront of what our office does. We want to make sure that older adult communities are offered guidance, tools, in providers are 100% proactive in follow-ups. And also we want to encourage long-term self-management. As I said, people should empower themselves and not anybody else empowering them. So we want to encourage long-term self-management without placing the full burden on the patient. And with that, I will pass it to my colleague, Ms. Danita Nash.
All right, and thank you, Juan. And Juan and Sandy, we forgot to acknowledge Heather Carter earlier because she's the reason for this partnership with our new partner. So thank you, Heather. And hey, okay, so let's talk. Our CPE framework and continuum that Juan just spoke about just a few minutes ago, health providers and communities work together to reduce disparities and improve outcomes for aging adults. How community partners can help. Community organizations can support healthy aging by sharing trusted health information, hosting community health education events, connecting older adults to services, reducing social isolation, advocating for accessible health care, and partners can also contribute through advisory councils, community boards, and public health collaboration. Next slide, Sandy, please. And working together for healthy aging. Reducing health disparities requires collaboration between state agencies, community organizations, healthcare providers, advocacy groups, and older adults themselves. And together, we can improve access to care, preventive health services, health literacy, health outcomes for all North Carolinians. And so here's the call to action. We can all help reduce health disparities. Now, I'm not sure if this is my slide or not, but do y'all want me to keep going?
I'm sorry, did I go too fast? Sorry.
No, that's okay. But
Okay.
everyone can contribute to reducing health disparities, and we all have a role to play. And here are some recommendations to make a difference. Focus on understanding and respecting different cultures when promoting resources and opportunities. Improve the capacity of organizations to provide inclusive language access. Address all aspects of a person's health, including healthcare access, healthcare quality, and social factors. Create a coordinated system of, of programs and services by forming more local partnerships, using tools like NC Care 360 and changing policies and systems. Join key NCDHHS meetings, events, and webinars to get involved. And you can learn more on our community and partner engagement webpage.
Yay.
So go ahead, Sandy. Is this your?
Okay, sure, I'll take it, Danita. Yes.
Okay.
So reducing health disparities requires teamwork, and that's our underlying message. It involves everyone, individuals, communities, businesses, healthcare providers, policymakers, government agencies, and more that we haven't even considered yet. Healthy aging requires strong partnerships between these organizations and groups, and by working together, we can improve healthcare access, strengthen prevention programs, and support healthy aging in all North Carolinians. Now we can discuss. So we can take those questions from early in the presentation. We don't mind going back and forth. No problem at all. Just let us know what you think.
Right. Mary, I think you had the first question.
Oh, thank you. Didn't mean to jump in there. So first of all, thank you guys for just relaying a lot of information and talking about, what you guys do and all. So the analysis report, Sandy, that you talked about, I assume that y'all used a whole lot of sources to pull together all that data and information.
Oh,
Is
yeah.
that right?
Oh,
Because I know I
yes.
saw a lot of BRFSS in there,
Oh, yes.
information. Um, so is there enough data in the report to do like a fact sheet on
Oh,
older adult
yes.
disparities?
Yes,
Or do y'all
absolutely.
or do y'all have one already?
Which
Like
population for senior disparities or for?
for older adults, yeah. Say
Yes,
people over
yes.
60. Whatever.
Absolutely. We do have one, and my intention was to share it in today's presentation, but it's not here. I do have it though. I can make sure you have it with your slide deck and also the feedback form. We also want to, we have opportunity to collect feedback from community that's so vital for informing the future rounds of the report. So absolutely, we have a few, actually, thanks for bringing that up. We have a few fact sheets that we've created for communities of highlight. There's one for African Americans, there's one for Latinx communities, American Indian communities, as they are called out a lot in the report. There's also one for LGBTQIA plus communities. There is one for, let me think. I think a one for women is in development now. And there's also slide decks with the disparities report for certain populations and for general audiences. And we have ways to capture feedback from all those all those communities as well. So there's a section on our website for data, and then underneath the report is a section for supplemental documents. There's everything from the fact sheets to one pagers to PowerPoint presentations, and there's also a social media toolkit if you wanted to say pull or share disparity from health across the lifespan. You could use an approved infographic that's there and the sample text and share it out through your social media. So that's available as well.
Yeah. And you probably heard that the Coalition on Age is going to be devoting a section of our website about health disparities. So I think one thing we'd want to coordinate with you guys about either linking to your site or even posting certain things on our site, then with a link or whatever. So I think
Sure.
that would be a really important resource to be included. But I do think that by focusing a lot on the fact sheet on older adults, it could help focus our efforts in looking at things that we might want to promote that we pay more attention to for sure. Because I
Sure.
mean, some of the data is very striking. I mean, you look at
Yes.
it.
And
That's,
I wanted to also interject that our office is also willing to have a discussion about what the best way it is to use those fact sheets. If
Mm-hmm.
those things that are going to generate either more questions or focus not so much on the gravity of the data that has been collected, but more in terms of focusing on solutions,
Mm-hmm.
find local resources. We promote the idea of partnering, as I mentioned in my section of the presentation. So we're happy to talk to any of you about what the most effective way to use the fact sheets and how to just prioritize your focus, because we know that people are right now, a lot of organizations and a lot of groups are being split in different ways and pulled in different directions. So we're happy to have that conversation as well.
I don't know if you guys have ever seen this, and I don't know if any people on the phone are aware of this or not, but the Coalition on Aging a couple of years ago had the opportunity to screen a film about the role that Medicare has played in older adult health. And I forget the name of it, but basically, I mean, Medicare has made all the difference in the world and the access of older adults to health care in this country. But that is it's a resource that you guys, if you aren't aware of it, you might want to check out. It is just really, really powerful.
It
Um,
is. It's
yeah.
called The Power to Heal.
Okay. I couldn't remember what the name of it
Yeah, and
was. Yeah.
Rosalie might be able to help us with getting that. That's really a great film.
But but
Wow,
that but that might be
powerful.
something you guys could use in your presentations too, because it really, I mean it's factual stuff, and it just basically talks about what it was like before we had Medicare in this country
Mhm.
for seniors. And
That's
that
right.
what we're seeing today with a lot of older adults is a result of not having access to care in their formative years, and all.
Yeah,
Right.
another piece that I think is important to mention in if we are trying to work diligently to be connected to those spaces so that we can participate, elevate, promote is the idea of how to work with caregivers.
Mhm.
Sometimes have the bulk of of having to not only be the navigators within a very convoluted system, but also they are half the time they're not compensated or they're not even thought of as part of the care process and care treatment for older adults. So that's a topic that we are also happy to address and to work with different communities to so that we can figure out even writing policy around how either Medicaid, Medicare, or any other safety net can start reimbursing caregiving as a service that's part of the treatment for to improve health. So yeah.
Since we're into the questions, Sandy, could you take the PowerPoint down and then we can
Sure.
see other hands easier, I think, in case
Love
people
to
want to
stop
talk.
sharing. My computer is a mess. Thank you so much.
Oh, you're welcome. Thank you. No.
And I'm glad everybody saw my note. I mistakenly referred to HR1 as Title One in my presentation. I meant HR1,
Yeah.
also known as the BBB. I don't say that. That's a person.
Mm. Do we have any other questions?
I'll just make another comment. So, in relation to HR1 or One Big Beautiful Bill,
Yeah.
so the state is going to be significantly impacted by this
Mhm.
legislation if no changes are made by Congress, and it's going to disproportionately impact, I think, people of color a lot.
Absolutely.
So we need, I think, as a state to be very, vigilant about our advocacy in 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 looking at what the ramifications are for how it's going to impact Medicaid, which in turn will impact the whole healthcare delivery system in North Carolina.
Yes, please.
Um, because I mean, if the state has to come up with $50 billion in savings in 10 years, which is what the projection is if no changes are made, that is just going to be dire in how, you know, and the impact it's going to have. And a lot of that's going to fall on older adults because even though older adults make up a smaller percentage of the healthcare expenditures and Medicaid expenditures in the state, or the numbers of people, they disproportionately make up for a higher
Mhm.
expenditure of total Medicaid budget. Because I mean, they such things as long-term care services and supports and things like that, they're just more expensive services to provide. So it's really going to have deep ramifications for older adults in general, but also for people of color in our
Mm,
state.
Absolutely.
very true. Very true.
One of the reasons why one of the things we do in terms of our first line of, I don't want to say defense, but our first line of action is to always talk to people and say, let's go back to the science. What is the data telling us? The data doesn't lie. Data doesn't have a political leaning. The data is showing that, especially in rural communities where there was already some, measure of lack, um, a lot of these issues are now being compounded. And so we need to focus on how
Mhm.
to handle that, deconstruct that, and then start refocusing on those things that we can address as priorities, and then go down the list and do it slowly and do it, mindfully. And so that's something that, at least for us, in our experience, it eases people's minds and especially for those folks that are very entrenched in their political views. We try
Mhm.
to massage that conversation so there is more about, let's talk about the science, let's talk about the facts, let's talk about what's going on and how it affects people personally. And then I think people are more likely to be more open to discussing shared solutions.
Mm-hmm.
And I also think we have to seize all opportunities to make an impact. And I don't know all the details, but I do think the Rural Health Transformation Grant that the state's got, and with the development of these hubs that are going to be, or established throughout the state, and what they're going to be doing with the local provider networks and things like that, are really things that we also need to find more about and see how that can have an impact on the work that we all are very interested in this area too.
Absolutely.
Mm-hmm.
I think another topic that, if you have questions, I'll shut up, but I was just mentioning another topic that doesn't get talked about usually, especially in larger forums, is mental health for older adults, and how
Yeah.
just uh, Alzheimer's and cognitive issues, which are major, which is great, and it still needs to be readdressed. But also, older adults experience depression, anxiety, isolation, and those things sometimes don't get the attention that they deserve. So that's another topic that we're trying to also make sure that we communicate with our partners about, and recognize and identify resources for it.
Mary Williams, I think, has her hand up.
Morning.
Good morning.
You can't see me, I'm sorry. First of all, thank you for the presentation. I am just really excited about the work that you're doing and the information that you shared. My day job is a policy manager with the Center for Black Health and Equity. And certainly we're living and breathing every day opportunities and working with communities to highlight the power that we have as communities to make a difference, to improve health for all, right? All of our communities. And so several things I wanted to highlight. As you know, we have spent time as a coalition highlighting the impact of Alzheimer's, but also doing a presentation to dispel some of the myths about Alzheimer's and dementia, right? You don't automatically get dementia because you're getting older, for example. We've also worked to highlight the impact of tobacco cessation strategies, and highlighting that just because you're an older adult doesn't mean that you should be ignored if you are continuing to use tobacco, that it's important to add years to your life if you know how to get help, and that it's important for you and your family to understand how to get help. So we are supporting a No Menthol Sunday initiative that we've been doing for years at the Center for Black Health and Equity, and we partner with faith communities. So I was really happy to hear you reference partnerships in the community partner framework. And so that's been an effective model that we've utilized. But I also want to just highlight and hear you talk more about families, because we know who's providing the care for older adults. It's families. It's stretched families, right? It's also children who are providing that care. So really understanding the power of, as we build partnerships, engaging families and educating families so that they can be more informed and have the confidence that they need to continue to impact the life and health of their loved ones. Because I believe communities is where our power lies, and where more than ever we're going to continue to rely on strengthening family networks and communities and building those informal family networks. So I just want to encourage you to continue to talk about those informal networks as well as those formal networks. Thank you.
Absolutely, Mary. It's amazing for me to see that across different cultures, the caregiving and the caretaking of older adults is usually the responsibility of the family, and it's not something that they feel necessarily obligated to do, but it's built in It's built in their DNA. It's built in their, how they see themselves as human being. And sometimes I wish that mainstream society would take into consideration that idea of informal networks that have historically done the caregiving, and also how, because it's not just recognizing that, but also how do we support families that are caregiving to to their elders. And so yes, that's definitely an area that we need to continue elevating and creating more resources for.
And if I'm not, just to piggyback on what Juan is saying, um, another element that is happening in our present reality, right, is we know that our senior, our aging North Carolinians that were already vulnerable are seeing a tearing away of that social safety net, the things that we put in place over generations to build for this population are being stripped away day by day, like never knowing what the latest breaking news is going to announce. So the idea, the concept of community is vital now, that we have to depend upon and see each other as partners, because that is going to be increasingly important, not only for the health things that we discussed, but getting access to food, getting access to information, making sure information is shared in a trusted network, to counteract misinformation, to getting into the meetings and places and spaces where policies are being discussed, like making sure that, hey, they're voting on this, let's get down there. But these things we can't rely on the old fashioned like newspapers and media. We have to knock on doors. We have to hold community partner meetings. And it's, as an agency, a state agency, it's vital for us, this community network, for exchange, not, bi-directional exchange, getting information to you and then taking that information back to places like the Minority Health Advisory Commission that we host on a quarterly basis. We have our minority diabetes prevention program that we have to tell you about, that we're expanding it and making it more available. It's a free minority diabetes prevention program, one of the only free diabetes prevention programs in the state. So making sure that resources and social programs that we have available, that people know about them. So I noticed during COVID that there was for me, it felt an intentional increasing message that we needed to distrust each other, and we weren't relying on each other as a community. It's going to be more important now that we unlearn that. But anyway, I'm babbling.
This is Sandra, and I just want to say thank you so much for the information. That's just really great statistics, and I think, as Juan said, you can't argue. Well, you can argue with the data, but it's data. It's data sets. It is where we are. And when I looked at some of those things that you were putting up on the screen, my first question was why? Why is that? And I think that's a question that we need to have other people help other people ask. Is why does that exist? Why is that there? Because that helps toward the solutions to make things happen. And as far as the advocacy, I was having this conversation with someone last week. I think the advocacy, the showing up at, in downtown Raleigh when they're talking about things is very important. But I think even more so, as you said, that literacy, that education to the general population, because what's even more effective is when that elected official is doing their monthly grocery shopping and one of their constituents comes up to them and says, hey, I read about this and I don't like this, and I think you need to do such and such about it, carries a lot more weight than a lot of the advocacy that happens. So that is so important, I think, and the coalition is very much behind that education piece as well. I've been at the coalition for a year. I know a lot more about older adults and issues and things, and I thought I was, quote, knowledgeable about those things, having served with a local United Way for over 25 years. But there's so many things and so many good programs that, as Juan said, there's so many solutions that are out there. We just have to get the people in need connected to them and figure out how we can make those connections even stronger.
Absolutely. Does anyone have any other questions, or because if not, we want to give you your time back so that you can, enjoy the rest of your Friday.
I just wanted to say thank you, and I appreciate the shout out, Danita. It was my pleasure. I'm so glad this worked out. It was a great presentation. So thank you all so much.
Thanks for having us.
Yeah. Rosalie, any final comments from you?
Yes, I just want to say thank you as well. Very informative presentation. Really appreciated you all taking the time to present to us today. I did want to just give a quick update on our next presentation that we're going to have on May the 8th. Lindsay Golding is going to be presenting about building healthy brain habits during Older American Month, and taking care of your cognitive health is more important than ever. And I was seeing if Lindsay was potentially on, but I don't think she is. But so that will be May 8th, 9:30 a.m. And we are looking forward to having Lindsay present on that topic as well.
Oh, I'm done.
Thanks everybody for being here, and we will post the information on the website. Sandy, if you could send Sandra or Daryl or Rosalie, somebody, the slide deck, we can put that up there also.
Absolutely. And then I'll make sure that you have access to the full report, the website, where these oh God, my words today, supplemental content. The only reason I didn't have the healthy aging fact sheet available today because it's currently being translated. We always provide things as best we can bilingual. So once I get that back from the translation team, that will be available as well. So happy to do it. And I'm, as the communications lead, I am constantly looking for opportunities to create new content informed by partnerships such as this. So I'm always taking feedback from our communities. And if there's something that is not expressed, a health literacy component or piece that you think should exist, please contact me. I'll put my information in the chat. Let's work on it. We love our co-branded materials.
Yeah.
And I see Betsy has her hand up if she has a question.
I do. Can you all hear me?
Yes.
Yeah.
I'm using these weird new headphones. Could you remind, I heard this mentioned, but I didn't catch, are the fact sheets that you mentioned on the state website, or are they?
Yes. Sorry, I'll let you finish.
No, go ahead.
They are. What we have so far is posted. The one that is for this particular community, it says Healthy Aging in North Carolina, is available, but only in English. And we make them for communication equity. We make them available English and Spanish at the same time. So as soon as I get the Spanish translation, I can post it. But I think I'm okay to share the English with the group with the slide deck. I'll double check on that. I think that's okay to do.
Okay. So the ones that you had broken down by like the African American community, the Latino community, are those online as well?
Yes, those are all available, and I'll drop as well as the fact sheet for rural communities, which we just used in time for a rural health transformation project. So that is also
awesome. Were you going to say you're going to drop that in the chat? Because if
yes.
so, yeah, thank you.
That one was of particular interest because there were a lot of people that are getting ready to try to get some funding, so they needed those. They need those epi dates. They need, facts for their support. So let me get to the web. Here's my page.
Dalton, you had something you were going to share also, I think.
I put it in the chat, but Office of Minority Health is going to be at the Rural Summit in 2 weeks for the Rural Resource Fair. So there's a table. I don't think any you folks are going to be managing the table. Hope you're going to attend, but if not, stop by and see them, and I'm sure they'll be able to have a lot of stuff, a lot of useful information to share there.
Yeah, we have, I think 1 or 2 of our other staff members are they're minding that table. We're down 1 staff member, so we're trying to make up for it. So that's why
Yes, we are in mourning. We are in mourning. We sincerely miss our Polly Jean Cox, who was with us. But we'll carry on. We'll carry on.
Well, thank you again, and thank everybody for attending. If no one has any other questions, thank you. I'll wait for you to put that information in the chat, or we'll make sure to have this up on our website probably early next week.
Yes,
as well.
The website also has our past reports, and people are already very interested in seeing what the next round will look like in the landscape of all of this. It's unfortunate that we won't get a chance to really see how Medicaid expansion closed some gaps because of all the things. Editing myself, all the things occurring with North Carolina Medicaid. I also include, let me see, an invitation to our, I think I shared it last time, our Community Connections with Medicaid call. It's a call that we share with our NC Medicaid team. They're always giving really great information about what HR, we're doing a 4 or 5 part series on HR1, what it means. People are asking their questions about the work eligibility requirement, changes to SNAP. It's very informative. I'm a person that, my eyes go cross when trying to figure out Medicare, Medicaid, and insurance. I need to not have that aversion because it is a reality, but I'll invite all of you to attend, and I'll also drop that in the chat.
We won't close out until we get your chat in there.
Oh Lord. I'm working with the world's slowest computer. Come on, computer. You can do it.
I see Dalton just put something in there too about the Rural Center has created.
All right. Here it is. Come on, get me right. It's CCM is connecting. It's so many acronyms.
Connecting with Medicaid.
Connecting community with Medicaid. Yeah, it's a great call. It's early, but there's the registration link. 8:15 to 9. I think 8:15 to 8:30 to 9. First Monday, or no, first Wednesday. Second Wednesday.
Early.
Yes. And I think that's all I got. There's more, but I'm going to hold back.
I have a feeling this is not the last time we're going to hear from you.
Oh, no, not me. Oh, no.
All right. Well, hey, we're 15 minutes ahead of schedule, so that's a good thing. Go make it productive. And everybody have a great day. Thank y'all for joining. We appreciate it.
Thank you.
Bye, y'all. Take care.
Bye-bye.